I'm not gonna go. Nobody around, all held up by the snow. And I can hear the sound of another Christmas song. And it feels like feels like a Sunday. Watch how the sun it creeps in, hanging straight out the window, getting high on a winter's morning.
Love it curls across the nation, I don't eat this up. Babe, I know that it's just over, could you bottle it up? Get down to the heart of it, no, it's my heart, your shit out of your luck. Don't make me tell you again. Woo! Love, love, love.
Hey,
Love, 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 love.
I do it for love.
Love, love, love.
Do it for. Yeah, do it for. Do it for. I do it for the love, Yes, I do. So you don't care about the money? Well, yes, it's true. And I'm so blessed to be fulfilling my destiny. All material things could mean less to me. Only thing I ever could need is a Sarah B sample with a dope ass beat and get the mic check. All the levels right, and if it's good, then I'll be here for several nights. Cause the only thing I need is a strong supporting team. The most important thing that helps supporting my dream. And I can't forget my family, helping keep my sanity. No matter what I do, I know they'll always stand for me. No matter what I do, I know they'll always stand for me. Yeah, I do as I can only do me. That's all I know. Dodge the difficulties and take life slow. And if I ever slow up, you know I always show up. It's still the same on me, even if I blow up. Love is what I do it for. Love is why I'm rapping. Love is the main reason for how all this happened. Love for all my fans, love for all the shows. Got love for all my memories, no matter where I go. Even if I'm out to nothing, I know there's always something. It's not a fitness test, but it'll always keep me running. One good thing about music, when it hits you feel no pain. So I keep it close to me, make sure it never goes away. From the start, I knew it in my heart. If I made one person happy, then I know I did my part. Now, if I stay into it and people dig the music I put on for my cities, and know I always do it for love. Yeah. Put on for my cities, and know I always do it for love. I do it for love. What you do it for? Do it for. I do it for love, for love, for love, for love, for love. For love, I do it for love. No pressure. I do it for love. I do it for love. No pressure. I do it for love. I do it for love. Yeah.
I set out on a road that I built with my own two hands. I met friends on the way, people chosen to make a stand. I felt strong in the sun as I walked onto pastures green. Saw forgiveness together as spaces in between. And I'll be with you through the night. And I'll turn every wrong to right. Baby, we're children of summer. We're meant to be free. Hearted, we're not like the others. No to places I've never been. But you can walk through this world without a few punches upon your chin. I think I lost you somewhere between 20 and 23. But I still hold you dear despite the heartbreak you caused in me. 'Cause you were with me through my nights, and you filled the darkness with shining lights, yeah. Baby, we're children of summer, we're meant to be free. Honey, we're not like the others, no reason to be. Lady, this fire in our lungs, so it's too hard to breathe. Lover, I live for the day you and I turn to me. I still think of you now, though my memories turning bleak. I'm still walking this road on my knees, they are ever so weak. I never thanked you for putting your faith on a bomb like me, yeah. And wherever you are, I think it's here you were meant to be. Baby, we're children of summer, we're meant to be free. Honey, we're not like the other, no reason to be. Lady, this fire in our lungs, so it's too hard to breathe. Lover, I live for the day you and I turn to me.
Yes. Uh, okay, I'm getting. Hi, everyone. Good morning. Hi, good morning, everyone. Thank you so much for joining us today for the City Case Study Session 2 for Asia Pacific region. Just a brief introduction. My name is Jessica Tia Mullen. I'm the Regional Director for Fast Track Cities Asia Pacific, and I'm based in Australia, where I am right now. I'm very excited that all of you are here to join us. We have some speakers who are there in Sevilla and some speakers who are calling in internationally. And to start off, since we're a little bit late today, I have Anna from ICAP at Columbia University from Almaty, Kazakhstan. Anna, please.
Thank you, Jessica. Hello, everyone. I'm very glad to be today with you and to present information about our project Almaty model for epidemic control. So first, just a few words about Almaty. Almaty is the largest city in Kazakhstan with a population over 2 million people. It was actually the first city in Central Asia to sign the Paris Declaration. Almaty signed Paris Declaration on July 20, 2017. However, there wasn't really much progress after Almaty joined the Fast Track City initiative. So by the end of 2019, the proportion of estimated people living with HIV with suppressed viremia was still very much below the desired target of 73% needed to turn the curve of the HIV epidemic. Because of that, Elton John Foundation, within its Radiant initiative, came up with the idea how to help the city to reach its 95-95 targets. And ICAP at Columbia University, together with several local organizations and Almaty CD8 Center, developed a successful proposal and launched the project in June 2020. The project is called Almaty Model for Epidemic Control, and it's designed to create and implement an effective, inclusive, and sustainable city program that works to achieve HIV epidemic control in Almaty. So here, just more information about the project itself. As I said, it's implemented by a consortium of local organizations led by ICAP at Columbia University. It's focused on people living with HIV and most vulnerable communities, including people who use drugs, men who have sex with men, transgender individuals, and sex workers. And it has three key aims. The first is to strengthen the city community-based and clinical HIV service delivery. The second is to remove or reduce barriers to uptake of HIV prevention, testing, and treatment services. And the third is to increase demand for HIV services. So because I only have 10 minutes, I will quickly run through some of the key objectives and key interventions for four focused areas. So for HIV testing, the key objectives were to improve community-based targeted HIV testing among key populations with prompt linkages to ART and prevention. Also, one of the key objectives was to increase access to and use of HIV self-testing and to enhance index partner testing. To achieve those key objectives, we implemented the following, we're still implementing the following key interventions. The first is network-based, peer-driven, incentivized recruitment of clients for testing. This was launched by the project last year and is very successful in attracting new clients that were never part of any HIV programs before. Also, at the end of last year, we launched an online self-test giveaway service that's currently being implemented successfully in Almaty. The AIDS Center runs an online and offline anonymous partner notification options. And also, we conduct routine and regular mentoring, support, and training of providers to ensure high quality of counseling for testing. For the second focus areas for HIV treatment, the key objectives included support to prompt initiation of all people living with HIV on ART, also to ensure effective patient follow-up and tracing to support ART restart after treatment interruptions, and to improve ART retention support and monitoring to prevent treatment interruptions. So the key interventions here were to intensive mentoring support to review data and to identify people who are not on ART, to understand reasons why they are not on ART, and to develop ART initiation plans. Also, we implement several active patient tracing efforts, and that happens in case of any missed visit for ARV pickup as well as clinical. Automated pre-appointment reminders for clinical visits and ARV pickup. And finally, we introduced performance-based incentives to providers to ensure all people diagnosed with HIV are initiated on ART. For the third focus area for the activities to improve viral load suppression, we have two key objectives. The first is to ensure high viral load coverage for all people on ART, and the second is to provide patient-centered approach to ART adherence. And for those two key objectives, we run a nurse-led home-based structured ART adherence support that's focused on patients who were on ART for 6 and more months, but did not reach viral load suppression yet. Also, we work to improve implementation of the multidisciplinary approach to patient management, and implement automated SMS-based notifications with viral load test results. And very recently, the project started to work on developing an implementation of Telegram-based bot and chat for peer-to-peer adherence support. For the fourth area, for HIV preventions, our key objectives were to ensure that all people from key populations have access to a basic package of HIV prevention services. Also, at the time when we launched, Almaty did not have a PrEP program yet, so our objective was to support the initiation and the scale-up of PrEP, as well as development and implementation of electronic PrEP register. So for the key interventions here included counseling and referrals to government implemented services, as well as training and mentoring of providers to ensure same-day PrEP initiation, dissemination of information about PrEP to key populations, people living with HIV and their partners, and also together with the Almaty AIDS Center and the Republican Center, the project was able to support community-based counseling and distribution of PrEP. So here on the slides, you can see the key successes of our 2.5 years of implementation. So the first and probably the most important success is improved collaboration between community-based organizations and the AIDS Center. This is now we see that as part of the project as well as beyond. So the community-based organizations and the AIDS centers are really working as one team to achieve common goals. Also, we because of all the training and mentored support, we feel that there is an improved capacity of service providers to deliver quality services. There is an effective network-based peer-driven outreach for testing model that's now being rolled out for people who inject drugs as well as men who have sex with men. We also were able to scale up self-testing through implementation of an online self-test ordering option and improve timing of ARTS initiation, as well as improve adherence support to patient. And finally, as I said before, the launch of PrEP in Almaty. And here you can see the changes in the cascade. Data, the baseline data is in red. It's from June 2020. And the green on the top is the June 2022 data. So it shows the progress of 2 years of implementation. So as you see, the estimate number of people living with HIV on Almaty increased a little bit from 5,000 to 5,300. However, we also see an increase in the percentage of people living with HIV who know their status, as well as both the number as well as the percentage of people living with HIV that are on antiretroviral therapy. And we see improvements in the viral load suppression rates. So there are some lessons learned, or how we like to call it, prerequisite for success that we learned from our implementation. The first is that close collaboration between clinical and community-based providers are very important. In our project, this is implemented through multidisciplinary teams that provide patient-centered care and also regular communication and exchange of data between various providers. Also, it's important to develop a system where routine data collection and analysis is implemented regularly, and targeted site-level support is provided to identify program gaps and develop quality improvement interventions. So our project uses patient lists to prioritize activities, link or relink diagnosed people living with HIV to HIV treatment. Also, we implement successfully performance-based financial incentives to community-based and facility-based providers, and also conduct individual and frequent data quality audits, mentoring and training support to providers on how to collect data, how to assess quality of that data, and how to improve quality of data. Use of technology allowed us to empower clients to manage their care a bit more actively. So we have several online and technology-based services, such as online service to order HIV self-tests, to notify index partners. Also, we, as I said, we implement appointments for ARV pickups and clinical visits. Patients receive their viral load results via an SMS service. Also, we use social media to provide information to clients, both the open as well as closed social media groups. And finally, uninterrupted supply of commodities such as drug test kits, et cetera, is also very important to ensure stable progress towards the set 95-95-95 goals. So what are the plans for the next year? So next year, we hope to finalize the development and launch an online distribution of harm reduction supplies. Also, we're in the process of developing a structured intervention to follow up of patients with severe HIV disease, hoping to reduce the existing mortality of people living with HIV. Also, we're hoping to start piloting decentralization of HIV services to the primary healthcare level. And finally, we're working together with the CD8 Center to develop a proposal to relaunch HIV mobile clinic, redesigned HIV mobile clinic that will help to reach populations that are currently not reached by facility or community-based services. This is all. Thank you very much. So if any questions, I will be happy to answer those. And also just want to mention that in the room, there are actually representatives of both the EJAF, the Elton John Foundation, as well as Republican Aid Center from Kazakhstan, CD8 Center from Almaty, and the project director from Almaty City Model. So they will be also able to answer some of the questions outside of the session as well. Thank you.
Thank you very much, Anna. Okay, so moving on now. I just found out that our next presenter from Bangkok is actually not joining us today. Unfortunately, she is not feeling well, so we'll have to skip past Bangkok and we're going to go straight to Jakarta. From Jakarta, Indonesia, we have Dr. Lies, Dr. Dwi Lestari from the Jakarta Provincial Health Office. I'd like to invite her to deliver her presentation.
Good afternoon, everyone. My apologies that the slide presentation isn't yet ready. So thank you, ladies and gentlemen. Good afternoon, everyone. I'm Dr. Dwi Octavia. I work for Jakarta Provincial Government, Jakarta, Indonesia. And thank you for inviting us to share Jakarta experience with special case study meeting this afternoon. And in this opportunity, I will present the topic of implementation of the Jakarta Fast Track Roadmap to respond to the HIV epidemic in Jakarta, Indonesia. Well, maybe some of us already know about Jakarta. It's quite a large city in Indonesia. We have total population of 11 million people for Jakarta only. And if we count the surrounding cities outside Jakarta, who usually the citizen also work in Jakarta and do commuter in daily routine, we have about 15 to 28 million people actually active in Jakarta in daylight. In Jakarta, we have 202 HIV counseling and testing services consisting of 143 hospitals, 44 health centers in sub-district levels, and 15 clinics throughout Jakarta. Maybe the third slide, please. The third slide, next slide, please. Oh, okay. And for CST ARV services, we have 149 services, consists of 90 hospitals, 44 health centers, and 15 clinics. And for viral load service, we have 36 services, consisting of 6 services in both in hospitals and public health centers, using the some of the we use gene export and some with the Abbott. All of those services are spread evenly throughout Jakarta province area, where every sub-district already has services for HIV testing and NRV treatment, so that easy access to service is no longer a problem in Jakarta. Those services are available for all people, including for the key population. For those who want free access, can access the primary health care or public health center and government hospital, but there are also private clinics and hospitals which also provide HIV services for out-of-pocket patients. Responding to the HIV epidemic in Jakarta, we try to develop programs in a systematic, evidence-based driven policies and according to guidance at the national level through Ministry of Health and global reference issued by the WHO. One of them is the involvement of Jakarta represent Indonesia in global commitments throughout Paris Declaration in 2014. Since the last 5 years, Jakarta province government has made various efforts and program innovation to respond quickly to the existing HIV epidemic, so that the goal of controlling this epidemic can be carried out. In 2016, it began to consolidate and prepare for the Jakarta Fast Track with the preparation of Jakarta Fast Track Roadmap document as a joint commitment, identify partnership collaboration at the regional level, and develop program tools. In recent years, various efforts from global and national policy adaptation have been implemented in Jakarta, such as the implementation of test and start, partner notification, loss and link in 2019, strengthening the implementation of viral load testing through JAK transporter, including the UNU demand creation campaign in it. Home-based ARV service delivery or JAK Antar. JAK Antar is in around 2020 through the course of pandemic, and also TLD initiation, multi-month dispensing, HIV advanced disease or AHD, and HIV self-testing and PrEP. The following slide are achievement of Jakarta based on people living with HIV estimate calculated by the Ministry of Health in 2020. This graph shows that Jakarta is the city with the most people living with HIV in Indonesia, with 65,000 PL-HIV or 12% among national estimation. It is red with the first target of JAK-Track, which is 95% PL-HIV new death status, then Jakarta is in a position of more than 100%. We reached 66,000 PL-HIV identified, diagnosed in Jakarta until now. Until the period of June 2022, in Jakarta, PLHIV has discovered 66,000, of which 30,000 were under ARV treatment at the moment, and 47% of people HIV found. It is read with the second target of fast track, namely 95% PLHIV on ART. Jakarta's position is at 47%. Then on the next bar, there are 27,000 among people living with HIV who during the ART treatment had performed viral load tests, where the viral load suppression rate was 93%, or 25,000 PLHIV had viral load suppression. And if it is read with the third target of fast track, namely 95% of PLHIV who are on ART experiencing viral suppression, then Jakarta's position is at 38%. The following slide describes the trend of HIV testing that had been carried out in Jakarta in the last 6 years until 2021. Seen an increase in HIV testing from year to year. From 2016 until 2020, but a decline due to COVID pandemic in 2020 and a bit rise again in 2021. However, in 2021, Jakarta will again increase HIV testing, which is issuing guidelines for the implementation of HIV program during the COVID-19 pandemics. If we look at the graph of the trend of HIV testing on the right, it can be seen that we are not only conducting HIV tests on key population, but also testing other vulnerable population. One of our innovation is conducting HIV tests on prospective brides, or when they prepare to go to marriage counselor, then we do also HIV tests for the couples. We have made it mandatory for prospective brides to have an HIV test before marriage. However, this result of HIV does not prevent them from getting married, but they are more careful not to transmit to other spouses or children in the future. One of which is the Prevention Mother-to-Child Transmission, or PMTC program, and index testing or partner notification approach. And in 2022, as explained in the previous slide regarding the program timeline, Jakarta has just released the HIV self-testing service, which is implemented by CSOs for high-risk communities and is supported by primary healthcare through the index testing approach. In line with fast-track commitment, we have started implementing a test and treat all strategy since 2017. It can be seen from the percentage of people living with HIV starting treatment that is getting better. Indeed, there are still people living with HIV who do not initiate for the following reasons. First, because they feel they are still healthy, and secondly, the patient is missing or lost after undergoing treatment at the hospitals. This condition is our concern by continuing of our partners, namely Linkage or EPIC Indonesia, by developing and implementing a performance threshold in every CST service in Jakarta. The result of the performance threshold analysis for same-day treatment or test and treat are consistently used for monitoring and evaluation in internal services, as well as by the district health office and public health office for further improvement. If we look at the graph on the right, we can see that the proportion of case findings is mostly found in the MSM population. And based on this data, information was also obtained that in other population, new people living with HIV are also found. This shows that there are still key populations that are hidden or have been successfully reached, And most of them were identified because they took an HIV test when doing an HIV test for requirements for prospective brides. The following is a profile of the new people living with HIV demographic in Jakarta. We can see the positive rate of its key population, which is again the highest in the MSM population. And there was also an increase in the IDU population due to an increase in the use of injecting drug use during the COVID-19 pandemic. But now the use of injecting drug has decreased again. If we look at the next graph, 82% of people living with HIV were found to be male, in line with the previous graph. The case finding was high in the MSM key population. Meanwhile, based on the age of people living with HIV, it was found that many of them were in the productive age, which is around 25 to 49 years old, and then followed by young adults, which is likely they have become a key population since adolescence. From this condition, we are currently conducting HIV education to adolescents through school-based program for reproductive health and information on preventing drug abuse, also as well as reproductive health services for adolescents integrated in primary health care service. We have initiated partner notification or index testing since late 2018 by developing guidelines with various workshops and consultation with the Ministry of Health, also informing several experts and practitioners from health services, and starting to be implemented since 2019. Partner notification, or PN, or index testing is a very good strategy in finding HIV cases effectively. It can be seen from the graph that the positivity rate of partner notification is 16%, higher than the positive rate of the MSM group. However, there are still obstacles in accepting offers. There are still many people living with HIV who refuse to do partner notification because they do not want to open their status or are afraid that their status will be found out by their partners. From the next graph, most of the partner notification that we run through patient referral, which means that patients themselves bring their partners to do HIV tests. And of the types of partners, most are sexual partners. One of the efforts to monitor retention of ART treatment in people living with HIV patient for people living with HIV patient based on data in their CST service, including lost to follow-up patient. Jakarta since 2020 has been running the loss and link strategy called Sehati, which is an acronym for strategy for lost, found, and linked back, or Sehati in English means one soul. Sehati, or this loss and link strategy, we developed two operating procedures, namely operating procedures for monthly meeting and for the tracing. For monthly meeting is a mechanism that regulates meeting between health service and tracers to discuss those who not attend to health service to get the ARV. And the tracing is mechanism that regulates the tracing of people living with HIV who miss appointment and to be contacted again and asked to come and take the medication back in their health service. From February 2020 to March 2022, 17,310 searches were conducted with the result that 9,500 PL-HIV have been recovered and approximately 3,400 or 36% are willing to re-engage or restart ART, and 2,500 have accessed ART again. We also saw that the search result identified that patients who had been categorized as lost to follow-up had died or were referred out of the services. An innovation during the COVID-19 pandemic with the aim of maintaining adherence to continue taking ARV and protecting people living with HIV from COVID-19 infection. This innovation is the result of collaborative discussion between Public Health Office, health services, CSOs, and NGOs. Multi-month dispensing criteria had ARV treatment for over 1 year. Good adherence, no symptom, monitoring, and treatment is still carried out every month through telemedicine. Of the 17,000 people living with HIV who are eligible to get MMD, 56% get a 2 months MMD and 9% get a 3-month MMD. For patients who are MMD eligible but cannot attend health service, they will be offered home-based ARV. So that ARV treatment is continued and people living with HIV do not stop treatment. From April 2020 until May 2022, there have been 9,400 people living with HIV who get home-based ARV, and 23,600 ARV were sent to their homes. PrEP is a prevention strategy that only been implemented in Jakarta from March 2022 until now. The program is still in a research protocol where there are 12 services in Jakarta that are becoming PrEP pilot services. From March to October 2022, there were 977 PrEP users, of which 80% from them are MSM key population. There are many challenges in implementing this strategy. For example, from a community perspective, because PrEP in Indonesia is still in the pilot period, where several laboratory test requirements must be carried out, which often becomes an obstacle for prospective clients because the process is quite long. In addition, there is an assumption of rejection from several parties in the health environment who think that PrEP will have an impact of encouraging key population to carry out risky behaviors without condoms and will then increase STI cases. Of course, this is part of our homework. We will respond carefully to this so that PrEP can run smoothly in accordance with the main goal, namely the prevention of STIs and HIV in high-risk groups while maintaining safe behavior, namely the use of condoms or the use of sterile syringes, especially to people with injecting drug users. Now we come to the end of my presentation, which is on what things will be the next strategy in improving planning and implementation of Jakarta Fast Track going forward. First, Jakarta will continue to optimize the recording and reporting of HIV programs from the HIV or AIDS Information System or SIHA version 1.7, which is currently in the process of being migrated as an effort to improve at the national level to SIHA version 2.1. It is hoped that the information system upgrade, which is facilitated by the Ministry of Health, of all HIV and AIDS programs data from the service level, city and provincial level, which ultimately to the national level can be more valid, timely, and accurate. So that data utilization can be carried out to produce further analysis of program improvement continuously. The second one, Jakarta realized that we need to increase the collaboration with all parties through a regional action plan, which involve all parties from the government, international development partners, NGOs, and CSOs. What will emphasize the paradigm of HIV issues is not only work in the health sectors, but also a multi-sectors issues that needs to get support from policy, budget, economic, cultural, social aspect to create an enabling environment. And the last, Jakarta will further improve the standardization of competence of health workers in all HIV services, as well as field workers from CSOs who work in Jakarta. It is intended that HIV service by CSO received by people living with HIV will have good standardized service based on professional and fair differentiated of care for the client. Thank you. That will conclude my presentation. Good afternoon, everyone.
Hi, everyone. Thank you very much, Dr. Octavia. Next up, we have Colin from Adelaide, Australia, who will be presenting in person. Colin, please. Thank you.
I think one of the great strengths of the Fast Track Cities meeting is that you can go from a presentation, which is such a fantastic overview and detailed overview of what's happening in Jakarta in relation to the 95-95-95 targets, to specific programmatic interventions like the one I'm about to present on from Adelaide. I want to thank the conference organisers for asking me to speak on this, this project. And I've done something that I never normally do. I've actually written my presentation because I've only got 8 minutes and there's a lot of ground to cover. So, the Connect initiative has been implemented by the South Australian Mobilisation and Empowerment for Sexual Health program, which is a partnership between Shine South Australia, a large not-for-profit sexual health organisation, and Thorn Harbour Health, the largest LGBTI health and wellbeing organisation in Victoria. So just to give people a kind of rough idea of the context of where South Australia sits in relation to the 95-95-95 targets, South Australia has a population of 1.8 million people. There are 1,460 people living with HIV, and unofficially, the figures are 94.3% have been diagnosed, 84% are on treatment, and 97% are virally suppressed. Now, let's see how this works. No? Okay. Oh. The Connect project was designed to tackle barriers to testing by providing free HIV self-test kits available through vending machines situated in discrete locations across metropolitan Adelaide. Now, in terms of tackling barriers to testing, obviously there's been an enormous body of research in relation to this, and there are a number of barriers to HIV testing that can include cost. Oh, no, I've gone the wrong way. There we go. Cost, stigma and discrimination, confidentiality, language or communication proficiency, fear of impact of visa status, familial, cultural and or religious beliefs and values, negative experiences with health providers, and low levels of sexual health literacy in the Australian health system. With regard to the process of accessing a test, it only takes a couple of minutes. The test can be carried out in the privacy of the user's own home, and results are available in 20 minutes. The Connect project provides information in multiple languages about follow-up and support services and prevention on the project website, and of course participation in Connect is anonymous. With regard to community consultation, and the project is kind of like an object lesson in co-design, if you like. At the commencement of the project, we established a cultural advisory group comprising of gender and sexually diverse members from China, Singapore, Chile, the Philippines, India and Australia, some of whom are employed in the provision of services to connect target populations. The advisory group meets monthly and brings knowledge of diverse community needs to all aspects of project development and implementation, particularly from the point of view of appropriateness of language and campaign imagery. All Connect support materials, the web page, the videos, subtitles, the test instructions for use, the campaign posters and vending machine messaging and follow-up survey have all been translated into 7 community languages, and obviously we're looking at the English version of the campaign there. These resources are then sent out to members of Connect's target communities for user feedback, and this feedback ensures that translated resources are both culturally appropriate and effective in engaging our target communities. With regard to the location of the vending machines, the Connect project is different from other similar rapid testing initiatives carried out in the USA, the United Kingdom and in New Zealand, in that in the main, it specifically targets international students. So we sought collaboration with 2 of Adelaide's universities, and vending machines were placed across these campuses in those universities. And this is the first pilot internationally to test the use of vending machines across university campuses, and usage in these locations has been significant. On average, the project dispenses 112 kits per month at university campuses. The other site we chose to install a vending machine was at the Gay Sauna, situated in the city centre. Overall, at all locations, university campuses and at the sauna, Connect dispenses on average 131 test kits per month, with a total dispensed to date of over 900 test kits, and we've been implementing since March this year. Okay. In terms of engaging non-testers and infrequent testers, one of the primary aims of Connect is to increase testing, in particular amongst target populations, as I outlined before, men who have sex with men, from culturally and linguistically diverse backgrounds, migrants and international students living in Adelaide. Data has demonstrated that 66% of all Connect users have not previously tested for HIV. 74% of those who access self-test kits from vending machines on university campuses have never tested before. Data collected to date shows that 48% of Connect users are overseas born. Of the 45 countries of birth of people participating in the project, the most common after Australia are China, India, the Philippines, Vietnam, Malaysia and Afghanistan. Now obviously testing is known to play a central role in prevention, early detection and treatment of HIV. While in Australia the proportion of HIV notifications is decreasing amongst men who have sex with men, it is increasing in some states among people who identify as heterosexual. In 2021, 63.6% of people reporting heterosexual sex as their exposure risk were diagnosed late, compared with 42.8% reporting male-to-male sex. And the proportion of late diagnoses was higher among people born in Central America, Sub-Saharan Africa, and Southeast Asia. In engaging culturally and linguistically diverse communities and making free HIV tests available on university campuses that are obviously accessible to anyone during business hours, Connect seeks to play a role in addressing the problems of late diagnosis amongst this group. 38% of all Connect users and 44% of those using university-based vending machines identify as heterosexual, and 47% are overseas born. Now, given the low rate of previously tested users, Connect also clearly provides a pathway to frequent testing and increased sexual health literacy for young people who might be at risk but may perceive that their risk is low. 71% of Connect users are between the ages of 18 and 29. To date, there have been 2 reactive results reported through the Connect project, and both cases made contact with the project workers for support and onward referral. In terms of user experience, one of our aims in developing the pilot was to ensure ease of access for users. Data from the Connect follow-up survey shows that we've been successful in that aim. 74% of those who responded in the survey said that they would be extremely likely or very likely to use a HIV self-test kit again. 92% of respondents said that they are extremely or very likely to recommend HIV self-test kits to others. The top 3 reasons given by respondents for using Connect were that it was convenient, that it was free, and that it's possible to access a test kit and test privately. Now, this project has demonstrated that dispensing HIV self-test kits via vending machines can overcome many of the barriers to testing, and obviously increase testing, and provides a practical and discrete process to testing access, referral pathways, and information related to HIV prevention to populations who would otherwise engaged in HIV testing, who would not have otherwise engaged in HIV testing, and will make a significant contribution to achieving the 95-95-95 targets. The formal evaluation of the project will be completed before the end of the year, and I'd be happy to share it with anybody who's interested in learning more about the project. I've got a number of kind of handouts, which includes a whole bunch more information about how the project was implemented and statistics of usage, which I'm happy to give out after. I'd just like to acknowledge the support of the Commonwealth Government of Australia to the Connect project, and to my colleague, Dr. Nikki Sullivan, who overlooks the implementation of the project in South Australia. Thank you.
Thank you very much, Colin. That was very interesting to hear, especially being here in Australia. It's always good to know what's happening just across the state. Next up, we have Dr. Vijay Kumar from Mumbai District AIDS Control Society. This will be a pre-recorded video, so seeking the technicians to help put that up. Thank you.
Good evening, everyone. Is that available? Pre-recorded video is available with you, or shall we start from our side? Hello.
Hello, yes. Dr. Vijay Kumar, are you hoping to join us live, or did you want us to load your pre-recorded video?
Yeah, start with the pre-recorded video. I will take the questions, if any, at the end of the video.
All right, thank you very much, Dr. Vijay Kumar. Technicians, if you hear that, please play Dr. Vijay Kumar's video, and then we will have him answer any questions if it comes out later. Thank you.
behalf of Mumbai District AIDS Control Society. Background for this study: studies have documented high rate of mental health disorders among the people living with HIVs. This prevalence varies a lot. It can be as low as 7% or as high as 83%. The common mental health conditions are depression, post-traumatic stress disorders, anxiety, alcohol dependence, or abuse. These mental health disorders may be substantial barrier in engagement and retention of HIV care. They may also contribute to poorer healthcare behaviors across the HIV care continuum with the poor health outcomes. However, studies have also shown that internalized stigma may reduce and mental health well-being may improve over time in PLHIVs. We design a mobile application, Samvad, means a dialogue, for counselors at ART centers to screen for mental health issues among PLHIVs during their routine care at ART centers. Friends, the method used during this study is all PLHIVs were screened with a simple tool to record their symptoms suggestive of depression, anxiety, and mood disorders in preceding 2 weeks. That's from the date of visit to the ART center. Common behaviors associated with these conditions were in the app to identify PLHIVs who needed mental health counseling. PLHIV with these symptoms were referred to mental health specialists for care. All the data were recorded in the app and regular follow-ups were to be also maintained in the system. Data from October 2020 to December 2021 were analyzed. We estimated proportion of categories variables. The proportions across groups were compared using chi-square test or Fisher's exact for low expected cell counts. We come to the results as among the 9,497 PLHIV screened, 1,033, that is 10.8%, had symptoms suggestive of mental health comorbidity. Gender distribution of PLHIVs with mental health comorbidities are male with 57.7%, female 41.3%, and male to female transgendered people is 1.1%. The common conditions were anxiety in 7.9%, depression in 4.5%, and mood disorders among 3.6%. Number of mental health comorbidities in PLHIVs: one comorbidity in 7.4%, two in 1.8%, and three in 1.7%. The median age of individual with anxiety was 37 years, and it was 35 years in those with depression or mood disorders. No association between gender and mental health comorbidities was observed. Patients with depressive symptoms were more likely to be virally unsuppressed. Depression and mood disorders were significantly more common in patients who were on a treatment for less than 2 years. However, there are significant difference in occurrence of anxiety-related symptoms. The conclusion: there is an urgent need for universal health screening for PLHIVs in routine HIV care at ART centers. Counselors at these centers should be trained to identify symptoms suggestive of mental health comorbidities and provide counseling or referral support to these individuals. An integrated approach to management of mental health morbidities will be useful for successful treatment outcomes in PLHIVs. These are some references for study. Thank you, friends.
Thank you, Dr. Vijay Kumar, for your video. Next up, I would like to welcome Dr. Junko from our incoming Fast Track City, Tokyo. Dr. Junko, please.
Okay. Good afternoon, ladies and gentlemen. I hope you can hear me well. I am Junko Tanuma, an infectious disease physician at AIDS Clinical Center in National Center for Global Health and Medicine in Tokyo, Japan. It is my great pleasure and a distinct honor to be here with you today. On behalf of all my colleagues working on HIV services in the country, I'd like to thank the conference organizer for giving me this special opportunity at this important meeting, even though any city, including Tokyo in Japan, has not joined the Fast Track cities yet. So I think my country has achieved a lot in HIV response, but my talk today is mostly about challenges rather than such achievement, including what we are planning this year with Fast Track City Initiative Institute. And yes. Sorry. So let me start with the epidemic chart. In the past decade, there has been continuous decline in the number of new HIV diagnoses in Japan. The annual number of the new HIV cases looks like at the peak in 2013, reaching nearly 1,600 cases, and since then, it is decreasing to about 1,000 last year. And I think this is mainly due to the guideline change recommended treatment for all in 2014. However, according to our group's estimation recently published in Lancet Regional Health, the speed of the decreasing trend is not enough to reach the global target, which is the end by 2030. In Japan, main group of key population is MSM, and our modeling study says we cannot eliminate HIV transmission among Japanese MSM by 2050 if no new measures are taken. But good news is that if we promote a combination of multiple tools of HIV preventions, we would be able to eliminate the transmissions with a realistic coverage target of each intervention. Then the COVID-19 came. As you can see in the graph of HIV testing number at VCT voluntary counseling testing centers in Japan, we have been facing the 75% reduction of the HIV testing number after the COVID-19. This is obviously the bottleneck in the promotion of the continuum of the care of HIV. The reason of the sharp decline of HIV testing was not just the stay home under the government declaration of the state of emergency of COVID-19, but also the shortages of manpower at public health centers, which belong to the local municipality and are running almost all public VCT centers in the country. The workers in the public health centers greatly contributed to the COVID-19 responses, which led to very low mortality of COVID-19 in Japan. However, they had to close or reduce their VCT services during the pandemic. So we need a robust mitigation plan in order to secure the access to HIV testing. Unfortunately, however, there have been more problems left unsolved since before the pandemic. At first, we do not have officially licensed HIV self-test kits, so the government cannot promote self or mail HIV testing in the government-led programs. This was very critical in the context of the reduction of VCT services during the pandemic. And second, the rapid ART initiation, enabling test and treat is still very difficult. The average time from HIV diagnosis to ART initiation is about 2 months or more because the patient have to submit 2 viral load testing results at least 1 month apart to get the benefit of physical disability certificate, which can cover most of the co-payment of 30% of expensive ART. And third, PRED has not been officially licensed. And fourth, the programs against stigma are scarce, and discrimination against people living with HIV in healthcare setting is common, both of which are, I think, the human rights issues. And all the key population who need PrEP, as well as all people living with HIV who need medical care, should have the access to those. And most importantly, the discussion and efforts behind these critical points are not always transparent. Nobody is sure to what extent we are reaching the solutions. So we need increases platform where all key stakeholders can get together, openly discuss, and develop the plans to make change happen. When it comes to cities' path to achieving the fast-track targets, of course, the cities are playing important roles, but cities cannot be on the fast track without the country's effort to secure the access of tools over combination prevention, like PrEP, RELT, or licensed self-testing. So we must involve the ministry for achieving the fast-track cities promotions. And let me just extend the introduction of our modeling team's result. If we look at the projection of future epidemic under promoting a single intervention of either of the behavioral or biochemical interventions, each target to coverage of requiring for eliminating the transmission looks really harder and even unrealistic. The prevention should be a combination of multiple tools ensure ending AIDS by 2030. Last year, the Japanese Society of AIDS Research, which is a nationwide academic association of clinicians, communities, and scientists working on HIV services, jointly organized the Fast Track City workshop with IAPAC, where we received very encouraging messages from Dr. Jose, president of IAPAC, as well as inspiring presentation from Dr. Nitaya in Bangkok and Dr. Jane Anderson in London. And in Dr. Jane's presentation, she emphasized the importance of the leadership group of much stakeholders in UK, and which I believe is the most critical element for the successful HIV response in London. With such huge encouragement, I am very pleased that the Japanese Society for AIDS Research has decided to accelerate the effort to break the barriers this year by creating the groups of multi-stakeholders to develop policy brief, which will be brought to the government, and by building the good partnerships with city municipalities and actively supporting their local HIV responses, and by signing the MOU with the Fast Track Cities Institute next month, which enables us to maximize the momentum with the power of this great international collaboration. And this picture illustrates how JSAR, Japanese Society for AIDS Research, will help communication between the cities, the government, and the Fast Track City Institute under the MOU in order to facilitate the collaboration among the parties. And we will create a concrete plan of programs where we can work together with the cities. And I hope that leads to the city's participation to the Fast Track City in the near future. And this is the summary slide. I'm not going to the detail again. And my talk is mostly about the challenges, but I hope I can share with you the great success and advance and progress in terms under this MOU. And I would like to wrap up my talk by acknowledging all the people who contribute to the Fast Track City Workshop Japan and everyone working together for ending AIDS in the region and the globe. And thank all the audience for listening my presentation today. Thank you very, very much. That's all for my presentation.
Thank you very much, Dr. Junko. That was excellent. IRPAC is very excited about the MOU next month, and we are looking forward to welcoming Tokyo into our Fast Track Cities network, hopefully sooner rather than later. And finally, our last but not least speaker, Dr. Edwina from Monash University, Melbourne, Australia. She's there in person. I'd like to invite her to give her presentation. Thank you.
Oh, thank you, everyone. And first of all, thank you to the organisers for allowing me to give a presentation. I feel honoured to be talking with my colleagues who've spoken before me. It's a privilege. It's been very, very interesting. And I'll begin my talk. I want to acknowledge that the country where I was born, where I come from, Australia, I want to acknowledge the traditional owners of the lands of Australia and acknowledge that they were never ceded to the colonisers. And these are my disclosures. And I thought it would be worthwhile to give some background on Australia. We have 26 million people, of whom 3% are Indigenous. Our background seroprevalence is 0.14%. 67% of new diagnoses occur in men who have sex with men, and we've seen over a third of a decline of notifications when you compare 2011 to 2020. We are a democracy, as I said. We have no treaty with the Indigenous people. It's to note. Importantly, I think very importantly, we have free healthcare for people who are residents or citizens of Australia, and we have a pharmaceutical benefit scheme which subsidises the cost of medications such as antiretrovirals and PrEP. We have had 8 national strategies. PrEP has been available on the pharmaceutical benefit scheme since 2018, and we have national PrEP guidelines. And we are able to ascertain on a regular basis PrEP use, and we estimate that about 50,000 Australians, we know 50,000 people in Australia have had at least one prescription for PrEP, so it's a fairly high uptake. Victoria, Melbourne is a fast track city. We joined fast track cities in 2016. There are about 6.5 million people in Victoria and Australia, and in fact I should say it's not just Melbourne, it's the whole state that's a fast track state, which was great that they allowed us to do that. We estimate about 10,000 people are living with HIV in Victoria, and we know that there's been about 14,000 people who've been dispensed at least one script for PrEP between 2018 and late last year. What this side of the slide highlights is a tremendously strong partnership response noted throughout Australia, but perhaps I might hope to boast that it's actually most well established perhaps in Victoria, where we have community, activists, clinicians, researchers, peak organisations and government working very closely together, and we have had done so for a long time. So here, for example, are some research precincts, different research institutes, the Doherty, the Burnett. We have Pronto, Thorn Harbour Health oversees Pronto, and we have one of the people who oversees the clinical care in the audience, drop-in centre for HIV testing and HIV care. We have almost all aspects of HIV prevention. We don't have a vaccine. Other than that, we have all opportunities for HIV prevention. I mentioned that you need Medicare for treatment. The Australian government has agreed to provide free antiretroviral therapy for people who have migrated to Australia and are not yet residents or citizens. And we are pushing very hard for PrEP to become available in a similar manner. And in Victoria, we've set up at the Alfred Hospital where I work a PrEP clinic which supports overseas born people who don't have Medicare we give them free clinical care and support them to find low-cost PrEP. I just wanted to show you that on this y-axis, it's the number of diagnoses of HIV in Victoria, and the units are in the hundreds. This y-axis is diagnoses in Australia. The units are more in thousands, and time from 83 to 2021. And you can see, obviously, we've all experienced this decline, and COVID probably led to the, well, I must say before COVID, we were already experiencing a decline, which we think is a result of PrEP and also the uptake of immediate treatment or rapid treatment when a person is diagnosed. But in 2021, we had 140 diagnoses. 63% were in men who have sex with men. That's coming down definitely from the high 70%, 80% it used to be in MSM. 23% were in heterosexuals, and importantly, 45% were born overseas. To give you a sense of where we are, these are data, we just don't have the updates, but at 2020, if you were to go on the Fast Track City dashboard, you would see for Victoria that we have had 90% of people diagnosed, of whom 92% are on treatment, and of whom 96% are virologically suppressed. So one important update was to let you know that we haven't yet released our new strategy. Obviously been given permission from the Department of Health to discuss it here, but soon to be released will be many plans, sexual health plans and others, but I want to focus on the Victorian HIV plan from 2022 to 2030. And we will aim by 2025, we've kind of got a bit of a pause. Within this long 8-year period, we thought we should pause and reassess ourselves, but we wanted to push hard and aim for, by 2025, rising from 90% knowing their status currently to 95%, rising from 92% being on treatment up to 98%, and rising from 96% currently to 98% of those on treatment having an undetectable viral load. So there are proximal targets for 2025. Also, again, an optimistic vision is for us to have the so-called virtual elimination of new HIV transmissions by 2025. An additional 2025 targets are that 75% of people will report a good quality of life. And we've heard some discussions here, including in a session during lunch, about trying to build quality of life targets into our care, the tough bit being which tools do we use to measure them. And another target is that 95%, I think this is really important, 95% of people at risk of HIV infection use one or more forms of effective HIV prevention. So you start to think about what proportion of people at risk are using good preventions. And by the end of 2030, we also hope to see that only 10% of people would report experiences of stigma, racism, or discrimination. A couple of projects we wanted to just mention to you was and these took a huge amount of work, was to set up medically supervised injecting rooms. Here's some photos here of this injecting room, which is in inner urban Melbourne and opened in 2018. People come into the injecting room. There are 20 booths where people can inject, and they get aftercare and are observed in case they overdose, and then there is a consulting zone afterwards. 74% of people who've come to this service are men. The average age is in their early 40s. 96% of visits are to inject heroin, and more than 6,000 people have used this facility. And at this consulting zone, before or after they inject, people can receive physical care for perhaps infections or wounds. They have opportunities for mental health care, bloodborne virus and HIV testing, housing, legal and financial services are available to these people. In Victoria, only 2% of people diagnosed with HIV report injecting drug use as their sole and principal exposure source. But about 10% of MSM also report injecting. So whilst this injecting room isn't entirely set up to prevent HIV, it's an important start, and it's a thematically important understanding of human behaviour and supporting people to come forward to be tested and receive health care. And finally, another key initiative that's happening in Victoria is sex work reform, the decriminalisation of sex work in Australia. And in February, what happened was that existing bills have been repealed. So a new sex work decriminalisation bill was passed this year, and that bill seeks to repeal a Sex Work Act and sex work specific provisions in the Public Health and Wellbeing Act. So there's two acts which are being modified to decriminalise sex work, and further reforms will occur in May this year and next year. And importantly, I think what I wanted to finish on were principles around, and these principles are key in any response to do with HIV and bloodborne viruses or monkeypox or anything where human behaviour and vulnerability sits at the core of the acquisition of a particular infection or illness. And that is equality. Equality for sex workers in this case. Sex work is treated like any other work, and sex workers are treated like any other member of the community. And here it's peer input, and we've heard from many presenters in the last 2 days the importance of peer-led work. So peer input is central to all policies and programs, and the preference is that it's a public health approach that will be taken over an enforcement approach. And I just wanted to finish with the peer group, note Vixen, it's a sex worker group, it's a subsidiary of a large national sex worker group, and they will be leading the education, the programmatic delivery to general practitioners and other healthcare providers about the decriminalisation of sex work and the appropriate health responses for sex workers. So thank you very much for your attention and your time.
Thank you, Dr. Adelina. This brings us to the end of our presentation. We have slightly under 5 minutes. Maybe I can open up for 1 or 2 questions. If there's anyone in the room or anyone online who would like to ask a question or direct it to someone else, please let me know now.
I'm just checking, ma'am. There was someone who presented, but who was on the 16:30 slot, which is the next slot in this program on mental health. So I'm just trying to check, how is the program going? Are we still on for the 16:30? Are you the one chairing? Because this person who presented on mental health was supposed to be on the 16:30 slot.
So to answer your question, our session will end at 16:15. So that's why we have a couple more minutes, but we will wrap up, and then I'm assuming the 16:30 slot will start when this room vacates.
Thank you. I do have questions, so I don't know if ever you can take questions. Can I go ahead?
Yes. Yes.
Okay. Thank you. Thank you very much. For the presenter in Austria, very interesting feedback. I just wanted to check in terms of the uptake of the males. Was it more self-referrals or they were linked? And what made it very attractive for such a huge uptake of 70, especially the male population, 74%? For the presenter in Indonesia, my question, especially for the home-based ARV, which I find it a very innovative strategy, is what was the criteria used to decide on the home-based ARV delivery? Who delivers the medicines? What is the form of verification? the security of the medicines, and how's the data capturing and recording managed? Thank you.
Jessica?
Yes.
Should I answer first or?
Would you like to, it's between you and Colin, so maybe since you have the mic, would you like to answer first and then pass the mic to Colin, if that's okay?
Okay.
I'm sorry, could I ask you to ask the question again? I just wasn't clear on the nature of your question. About the 74%?
So basically, what was appealing with the uptake? Was it self-referral or were they up-referred?
Yes.
And what made it very interesting was, especially for the main population that we struggle with, I find it very interesting that it was very high. So, you know, what was so different that made it such a huge, where they linked because somebody linked them, or it was because they just referred themselves?
Yep. So I think two things came into play. It's an incredibly novel intervention, so people were interested in the nature of it. In terms of uptake, it was entirely self-motivated, although, you know, the percentages that I presented towards the end of the talk in relation to being able, you know, 92% of people said that they would be highly motivated to recommend it to others. So there's obviously a degree of community talk about the project. But the other thing to emphasise about this particular project is it was funded by the Commonwealth of Australia, and they provided us with a very generous budget in relation to social marketing of the initiative. And so we had a very big public-facing campaign for the project. So a lot of people in metropolitan Adelaide would have known about the Connect project, and of course, allied to the novelty of the intervention meant that there's been quite a high uptake of the initiative, and in fact, higher than any other similar project around the world. But I'd be happy to provide you with some more information.
Thank you for the question. For Jakarta, well, for the multi-month dispensing program, we select the patient based on their adherence to treatment history. We only give the multi-month dispensation for those who already 1 year or old in the HIV service. So, and also for those who has good adherence, no symptoms of HIV, of AIDS, and no suffering of other serious illness. So for this patient who met the criteria, then the doctors in the the HIV service center will discuss with the eligible patient. And when the patient met all the criteria and agree to have the MMD service, then the routine medication who sent to his or her homes will be first is based on the patient called to the health center when the medicine is about to finish for every month. And after the consultation, and the medication will be sent to the homes using the courier service. And the data record is using the same data recording with other patients who regularly visit the health service. So, and the drugs is the same with the history of medicine that the patient had. So no change of medicine. And after the medicine is received by the patient, then they can consult with the doctors from the health service if they have any questions about the condition or the treatment. And it is, we give 2 months or 3 months dispense medicine based on the logistic supply availability and also with the patient condition. Thank you.
Thank you, Dr. Octavia, and thank you, Colin. I guess that brings us to the end of our session. I would like to thank everyone for joining us today.
One quick last one. On the Japan studies, I just wanted to check what is bringing, what is challenges in relationship to bringing back or doing HIV testing after the COVID pandemic. Why are you not seeing increasing numbers for HTS when the pandemic has gone down and almost not there?
Thank you for your questions. And as I mentioned in my presentation, the main drive of the HIV testing reduction would be first, start with the stay home by the government, and but then perhaps or maybe the most of the previous test taker would be the repeater of the testing, HIV testing, and they are now not willing to take the HIV testing. And also, I think during the pandemic, among the MSM, the public attention to the HIV issues and as well as the importance of the HIV testing among the high-risk population is decreasing. So maybe we have to encourage them back to the HIV testing services. So the promotion is necessary. Yeah, I hope my answer strikes your point.
Thank you, Dr. Junko. I'm sorry, but I think I have to wrap this up. We have to give up the room to the next session that will start at 16:30. Thank you very much to all of you who have participated virtually and in person today. This was a great opportunity for all of us to share ideas, especially with fast-track cities, which are geographically closest to us. And as a regional director here, I would actively work to establishing closer ties between the fast-track cities of our region. I'm sad that I can't be there in person with all of you, but I hope you will take the opportunity to have great discussions with each other off the program. I wish you all the best for the rest of the conference and safe journeys home. And for those who are joining virtually, thank you very much for your time. Good evening and good night. Bye, everyone. Thank you.
Testing. Buenos dias. Hola. Hello. Can I get your attention? Everybody's here for session 2, HIV 2, right? Thank you. My name is Shalone Savant. I'm with IAPAC, and I'm the moderator for this session. And I just want to quickly run through and see who is here, because we might have some people missing. Is Jitendra Misra here? No? Okay, we are in the right room, right? España 2-3. Okay. Okay, we know Elska's here. Is Harry Coleman here? Great, thanks, Harry. Carmen Nicole. Carmen from Yaoundé? No. Okay. Dorothy Okech? Is anybody online? Dorothy Okech was maybe online. Is she online? Okay. Dorothy, can you hear us? Okay. Mpefe's here. Noah Mancuso? Great. Okay. And the last person is not here. Okay. All right. So we are missing this one. But everybody else, and Jitendra's not here. Let me just look outside. Jitendra? No? Okay. Yes, it is. HIV 2.
Okay, because the room over there says HIV 2, and I think that's used also.
Wow.
They
Okay.
didn't have the speaker that they were looking for. This room over here.
See, this
that
is
one right there
5.
says HIV 2.
Oh my goodness. Okay, well let's just
Right
thank
there.
you.
Yeah, oral abstracts HIV 2.
This is strange. That's yes. España 2-3. Okay. Iman? We have a problem. Do you know this room has people? The speaker, Jitendra Misra. She's supposed to be in this room. She's virtual. Jitendra?
I haven't heard of it.
Okay, sorry. There are people that are supposed to be here that apparently went into that space.
No, so far we looked at the list. We're good with the names of speakers and number of speakers.
So everything's fine, because
Yeah.
somebody was on a
The
different.
names are
Okay, sorry. Okay. Then, okay. It seems. Okay. Test. Okay. I think we'll go ahead and get started so we don't lose time. We'll start with the second presenter because the first one is not here. We still don't have Jitendra. Do we have Jitendra Misra? No. Okay. Thank you all for coming. Sorry for any confusion. We'll start with session 2, with presenter 2. Are you ready?
I'm ready, but I don't know if my slides are my presentation.
Did it get sent to the...
I did send it by email, but I'm not sure whether they received it.
Okay.
Maybe they can confirm.
Okay, I think we can skip. Can we skip to Harry Coleman? Are you ready? Okay. Do you want to join us at the table here? Okay, great. Dorothy catches online. Pefe is there.
Would you like us at the table?
Yeah, I think it would be great. Noah, if you can join also. Harry, Dorothy, Pefe. Okay, do we have the slides for Elxa? Do you have the email yet? Not yet? Okay. Do you have the slides for Harry Coleman, Achieving Virological Control, number 1225? Apologies. Do you have 1225? This one? Oh, you do have this one? It's an email, just came to you.
This one is not there. This one is not. So we have to pass this.
That's okay, we'll pass it.
Yeah.
1, 2, 2, 3.
So empezamos con la segunda porque la primera no está ninguna.
This one here?
Yes, this one is esta es la que te manda ahora mismo.
Okay, you ready? Okay, thank you. Okay, we will start with Elxa. Elxa Hornenborg will present on the intention to use long-acting HIV pre-exposure prophylaxis among men who have sex with men participating in the Amsterdam cohort studies.
Enciéndelo. Enciéndelo. Marta, está apagado el mic.
Yes.
Is it working now? Yeah, wow, thanks a lot. I'm presenting here on behalf of my colleague, Jeffrey Kohler. He couldn't be here, but he's the one who did the vast body of this research. We have nothing to disclose. So what it's about? Well, it's about long-acting PrEP. Currently, we don't have it available. We only have oral PrEP available in the Netherlands, and we prescribe it either daily or on an event-driven schedule. But there are studies showing promising results on safety, tolerability, and efficacy of novel long-acting PrEP formulations. Although, unfortunately, the islatravir now has been halted for further development for PrEP, which is really a disappointment. Long-acting PrEP is a very valuable option for people who have issues with oral PrEP use. So this is where we came to our study aim. What are the intentions to use long-acting PrEP among men who have sex with men in Amsterdam, the Netherlands? What did we do? We used the Amsterdam cohort studies, which is a longitudinal observational cohort study, which started long ago, 1984. It focuses on HIV, STI, and other infections, and also on sexual behavior on MSM in the Netherlands. For this data collection, we sent out an online questionnaire, we described a little bit what long-acting PrEP was, and we said, well, there's basically 3 options in the future available as we think: a monthly pill, a 2-monthly injection, and a yearly implant. We asked for the intention to use long-acting PrEP, and we assessed this by a 7-point Likert scale. 2 questions combined. If more than 5.5, we defined it as a high intention. And we asked for expected effectiveness, side effects, and adherence of long-acting PrEP. Well, almost 90% of the participants completed the questionnaire, 477. The median age was 45 years old. It's not a very young cohort, which is understandable because it's such a long-lived cohort. And less than a quarter, 24%, had ever heard of long-acting PrEP. A high intention to use was reported by 36% for oral long-acting PrEP by monthly pill, 18% for intramuscular long-acting PrEP, 2 monthly injections, and only 9% for subdermal, so an implant. Having a high intention to use long-acting PrEP in the future was associated with having ever heard of long-acting PrEP, with adjusted odds rates between 1.4 and 3.2 for the different formulations, as you can see there, and a high expected effectiveness of long-acting PrEP with an adjusted odds ratio of about 1.5. So, main findings of this research is that awareness of long-acting PrEP among MSM in Amsterdam is still very limited. Intention to use it was moderate for oral monthly pill and low for intramuscular or subdermal use. Having a high intention was associated with having ever heard of long-acting PrEP and a high expected effectiveness of long-acting PrEP. So this brings us to the discussion. This long-acting PrEP is not yet available in the Netherlands, and whether it will be available is highly dependent on the costs. The oral PrEP pill is quite cheap at this moment, about 10 euros for a month or 20. If the long-acting PrEP will be much more costly than that, I'm not sure whether it will be implemented on a large scale. But when the options become available in the Netherlands, it's important to create awareness and to inform MSM about long-acting PrEP to ensure uptake and MSM being able to make an informed choice that suits them best in their needs. Acknowledgements to all the participants and the study team to collect the data, and to all the co-authors on this study. And this is the end of my presentation.
Thank you very much, Elsa. Okay, we will take our next presentation. Harry Coleman is presenting on achieving virological control and engagement through tailored peer mentoring, a collaborative project supported by the Fast Track Cities initiative. Thank you.
So thank you very much for inviting us to give our talk on this project, Achieving Virological Control and Engagement through a Tailored Peer Mentor Project. My name is Harry Coleman. I'm a doctor who works in London.
Y yo soy Jaime, trabajo para Metro Charity. Gracias por la oportunidad de presentar nuestro trabajo y conocer esta preciosa ciudad.
Brilliant. So, just for some context, in London and the UK, the vast majority of people living with HIV are on treatment and undetectable. But clearly we know that incomplete adherence to antiretroviral therapy and difficulty engaging in care can result in increased morbidity and mortality. And so we designed and implemented a peer mentor project dedicated to look at patients who might find it difficult to engage in care and difficult to take regular antiretroviral therapy. So patients were eligible to be referred to the peer mentor if they had a viral load greater than 200 copies. And this was a collaboration between 2 large HIV clinics in London and the Metro charity.
So the aim for this project was to ensure that 60% of patients engaging with a peer mentor, in this case myself, would achieve an undetectable viral load within 12 months of referral being made. With that in mind, we put together some promotional materials, define a referral pathway, and develop a contact, first script contact with patients. All the support plans that we put together were developed in partnership with the client themselves, with the patient, so it's individually tailored to address their needs. I was working remotely while the pandemic, but since June 2021, I've been embedded at both clinics, at the Harrison Wing and the Caldecott Center.
So I'd like to take you through some of our initial results. So these are up to month 20. So we had a total of 81 patients referred into the program. And since then, we've had up to 96 patients, so continuing to grow as well. Of those referred, 40, so around half, engaged with the peer mentor. And you can see that these are patients who in the past have struggled to engage in care and perhaps to take antiretroviral therapy, with median CD4 counts already less than 200 and high viral loads in the 100,000s. We also had a look to see whether there was a difference between those who engaged with the peer mentor versus those who did not engage. And the only significant difference we found between the 2 groups was those who did not engage had higher numbers using recreational drugs. And I'd just like to take you back to the project aim, which was for 60% of patients to achieve undetectable viral load by 12 months of referral. And here we can see that we vastly exceed our project target, which is incredible. So already by month 3-4, we had 60% of people who referred into the project achieving undetectable viral load. And our highest number was 85% of patients within the project engaging, achieving undetectable viral load, which is incredible.
So this graph here is the top 10 topics as they presented in the support plans of everyone that had engaged with this program. So HIV knowledge, it's the first topic because we make sure it's important for patients to understand what it means to become undetectable, understanding the CD4, viral load, adherence, side effects, and all of those issues that will help them manage their HIV. I was personally surprised that stigma wasn't higher on the list, but I guess disclosure is a byword for stigma. If there wasn't stigma, people wouldn't struggle so much to disclose their status. Mental health is a prevalent issue among the people that we support, adherence, as well as all the other topics that you can see listed here. We have 3 case studies to share with you. The first one is a 25-year-old heterosexual young lady, Black British origin, vertical transmission. At the time of referral, her CD4 was 140 and the viral load 2,500. So the background for this patient, we met while she was an inpatient. She had a PEG tube put in place so she could treat her HIV. She's unable to take medication in pill form. Her family background is quite complex, including prejudice against women, sexual health, there's some abandonment issues, and that's directly linked to her adherence problems. And there's also PTSD associated with the medication, plus drug resistance. At the time of referral, she was on temporary accommodation, and her mood was very low, including suicidal ideation. So her support plan, which we developed together, included various topics. I'm just going to highlight the one that I think was more relevant, and in her case, it was assisting and advocating on her behalf so the PEG tube could be removed. She was seriously struggling, it was very painful, and she had to look after it and clean it, and it was very complicated. But eventually, we were able to liaise with the medical teams at the Caldecott Center, and the PEG tube was removed. In the process, to transition to injectables, she had to learn how to swallow pills, which is never a bad skill to have. And she learned to change her thinking regarding medication from something that's harmful to something that is helpful to her. She was able to secure accommodation, and she's now on monthly injectables and virally suppressed. The next case is a gay cis male from Bolivia. His CD4 was 317 at the time of referral, and the viral load 176,000. The background, various complicated issues, including homophobia within his family. And that experience led to his exposure to HIV, self-acceptance. He wanted to punish himself and his family for being gay. So issues around self-esteem, migration as well. He's been in the UK for 20 years, but has learned the language, so which is a barrier for him, as well as the side effects related to the medication. There's a total disconnect with his medication. I remember speaking with him and encouraging him to find his pills so he could take them while we were speaking. He didn't even know where they were and the names for them, so he had to acquaint himself with the meds. His support plan included various topics. I'm going to highlight faith and sexuality, which was important for him. He promised to his mom on her deathbed he wouldn't be gay, so he's seriously struggling with that, religion, family, as well as the regime change support. He went from 3 pills to taking the 1 pill, Biktarvy, which he can take with without food. It made adherence so much easier for him. So he's now more aware of the health risks of not managing his HIV. He's reduced his alcohol consumption. He's now more hopeful about sex and relationships. And luckily, through the Harrison Wing, we were able to offer monkeypox vaccination, which he engaged with. He also engaged with mentoring wrap-up. This is something we offer when people become undetectable to honor the mentoring exchange. We cannot go from sharing deeply personal information to now you're undetectable, bye. So wrap-up helps us conclude the mentoring exchange, make final referrals, signposts if necessary. And now we have also offered monthly catch-up for those people that have struggled to become undetectable and to make sure that we can support them on a monthly basis so they remain undetectable. And the third case is this lady, 55-year-old lady, Black British, CD4 at the time of referral, 197, the viral load, 112,000, quite high. Although she was diagnosed with HIV in 2009, she had never achieved viral suppression. At the time of referral, she was coming to terms with the death of her daughter, her dad, so she was feeling really low. She looks after her grandchildren as well, and has various phobias, including claustrophobia, vertigo, agoraphobia, food allergies, various other issues. Although she's very enterprising, she was feeling really low about herself and isolating herself. And the main issue for her was the pill size. It was too big, she couldn't swallow it, she had to cut it in half or crush it, which made it taste really bad. So she wasn't adhering to her medication. She was referred to various services, including Metro Family Support Group, Positive Plus One, Living Well, the Girls Project, also funded by Fast Track Cities. And she's now reduced her viral load to 202, which is quite an achievement for her. She's naturally inclined to help and support her peers, so she's engaged with training to become a mentor herself. And I think it's great that we can support that journey, full cycle of entering the service as a user and then coming out as someone who is able to give back to the community that she belongs to. So the main takeaways from this project so far are around simplifying information. Even if the clinicians try to explain what CD4 viral load mean, they often don't understand. So I use a simple metaphor to accommodate for language barriers or other barriers, cultural, that might interfere with their ability to understand why they take this medication and what the doctor is telling them when they go to the clinic. So basically I tell them, think of your CD4 as your army. You want to have a nice, strong army. The viral load, think of it as Godzilla. If your army is small and Godzilla is this freak monster, then you are like slapping Godzilla and Godzilla is laughing at you. So the antiretrovirals are the weapons. You are weaponizing your immune system, and then you make Godzilla become so small they can't even find it. It's undetectable. And that's the information that will hopefully empower them to engage with the healthcare that will keep them healthier for longer. So as we mentioned, we offer mentoring wrap-up, monthly checkups, and I think it's worth keeping in mind boundaries as well. Often they share information with me they haven't shared with anybody else. And especially during the pandemic, it was like a very close experience that I describe as boundary bonding. There is bonding that takes place but needs to remain professional and boundaried. So there's the mentee to mentor cycle. Not everyone is engaging with this, but it's great to see some of them wanting to give back to their communities. Also, despite our best efforts, not everyone wants to engage with medication, with the clinics, with health, because other things take priority: migration, homelessness, mental health, chemsex, various other issues. And also clinical supervision for the mentor would be advised. Sometimes it does get quite intense: suicidal ideation, homelessness, really precarious situations. So any support that can be provided to make sure that the mentor can do his job well is going to be more than welcomed.
So we have shown that through a collaborative approach, peer mentor embedded within a HIV clinic can engage with some of the most complex patients and clients that we see. And we believe really that it should be the gold standard for all HIV clinics. And we'd like to thank all of the patients that were involved in the project and the Metro charity.
And also Hannah Alexander, Kay Childs, and Holly Gaidari, sorry, Goli Haidari, pardon, for all the support they've been providing us. This project wouldn't be what it is without their assistance.
And these are just some comments and feedback from some patients that were involved within the project. Thank you very much.
Thank you very much. We'll just save questions for after. Thanks for the presentation. And thanks for the first one. We'll save questions. Okay. Our next presenter is online. That's Carmen Lawandi Matthias Nickel. Can we make sure we have our online? Carmen will present on experience of the implementation of the one-stop shop strategy in programs to fight against HIV/AIDS among young LGBTIQ people in the city of Yaoundé. The case of fades in Yaoundé 5th, Cameroon. Okay, over to you, Carmen.
Bonsoir tout le monde. Je vais faire la présentation de l'expérience de la mise en œuvre de la stratégie One Stop Shop auprès des populations clés dans le cadre de la lutte contre le VIH, ici en particulier pour les personnes LGBTIQ de la ville de Yaoundé. Je suis le directeur exécutif de la CAMFED et depuis 2009, nous mettons des programmes de lutte contre le VIH et des droits humains en direction des personnes LGBTIQ au Cameroun. Depuis une quinzaine, une vingtaine d'années, il y a un ensemble de programmes de lutte contre le VIH qui sont mis sur pied par différents programmes et par différents acteurs au pays. Et on s'est rendu compte que nous rencontrons un essoufflement en termes de mobilisation. Et lorsque nous faisons des descentes sur le terrain, la plupart des pairs que nous rencontrons nous demandent qu'à part votre VIH, qu'est-ce qu'il y a d'autre d'intéressant dans votre centre? Nous sommes à peu près fatigués d'écouter VIH chaque jour dans votre centre. À titre de rappel, la prévalence nationale est de 2,7% et au sein de la communauté des homosexuels de Yaoundé, elle est de 44%. C'est pour vous laisser voir un peu le défi qui est le nôtre. Et enfin, d'encourager et de comprendre ce qu'il fallait faire pour améliorer notre offre de services en matière de VIH/SIDA. Nous avons organisé en 2020 4 focus groups avec différentes tranches de population pour voir à peu près quelles étaient les attentes, quels étaient les autres services qui étaient susceptibles d'intéresser les bénéficiaires à qui nous voulions offrir nos services. Et on s'était rendu compte que parmi les services qui étaient les plus sollicités, il y avait beaucoup de services juridiques parce que le contexte camerounais est un contexte de pénalisation de relations sexuelles entre les personnes de même sexe. Donc, il y avait également les tests d'IST, d'autres IST, hormis le VIH, il y avait les services de laboratoire, il y avait tout ce qui était service sur le genre et les identités. Et au regard de cela, avec nos équipes, nous avons essayé de greffer un ensemble de services connexes au service de dépistage du VIH. C'est comme ça que nous avons greffé ce que nous avons nommé Gender Café, qui est un café où on permet aux personnes d'exprimer toutes les incompréhensions qu'ils ont sur les orientations, les identités. Nous avons également des cliniques juridiques qui étaient annexées à nos services. Nous avons des services de laboratoire qui étaient ouverts à toute la communauté LGBTIQ parce qu'il faut préciser qu'au Cameroun, seules les personnes HSH et les transgenres femmes ont accès aux services de VIH. Nous avons ouvert les services aux femmes lesbiennes et aux transgenres hommes. Et nous avons vu que nous avons pu, après un an d'expérimentation de services associés, nous avons pu augmenter de 70% notre capacité de sensibilisation contrairement à l'année qui était passée. Nous avons pu toucher 40% de plus de la cible dite hard to reach, qui était une cible très, très difficile à toucher par nos services. Nous avons entrepris d'améliorer l'offre de services et avons organisé d'autres groupes de
Camden,
parole.
sorry, do you have slides? We're not seeing a presentation. We're only hearing you in French.
A slide in French too.
Okay. Parlez-vous anglais? No?
Int'l.
Okay. No, it's all right.
Okay.
Thank you. Carry on.
OK. Thank you. Comme leçon apprise, on a vu une augmentation de la visite du centre et une bonne communication une bonne relation entre le grouping center et les populations, et surtout avec un nouveau type de population qu'on n'arrivait pas à toucher avant, une cible qui est dit hard to reach et qu'on a réussi à toucher de manière significative dans le cadre des projets que nous menions, notamment les projets liés au Fonds mondial ou bien les projets liés au PEPFAR. Nous avons eu des atteintes significatives de nos indicateurs sur les 3,95 et c'est grâce à cette approche de jumeler les services dans le grouping center. Ainsi, donc, nous avons présenté cette approche à d'autres participants et à d'autres organisations qui ont commencé à l'implémenter. On a vu que on pouvait également avoir les mêmes résultats. Donc, l'avantage de cette approche, c'est qu'elle permet de toucher une nouvelle catégorie de personnes que les services classiques de VIH ne touchaient pas déjà. Elle permet d'offrir des services de manière holistique et elle permet d'aborder également d'autres questions connexes à la question liée au VIH, qui sont les questions des droits humains et les questions de genre. Donc voilà en quelques points la présentation que je voulais partager avec vous. Merci beaucoup. Thank you very much.
Merci beaucoup. Merci. Okay, our next presenter is also online, Dorothy Okech. Dorothy, are you with us? Dorothy will present on the following. Does collaborative workplace HIV self-testing kit distribution improve case identification among men aged 18 to 34 years? A case study for Kisumu County, Kenya. Dorothy Okech. Dorothy, can you unmute? Do you have slides?
Yes, I have slides.
Okay, just a moment. How do we change the echo?
I already sent my slides.
So she needs to have two. Okay. Dorothy, you have two computers on. You need to turn one of them off because we have an echo. Can you take one of the devices off?
Yes, that's possible. I'm just doing that.
I can't hear you now. Okay, thank you.
Are you able to hear me now?
Yes, we hear you. Thank you. Just one moment. We live in such a technical world now, and it often doesn't work exactly like it should. Thanks for your patience, everyone. Okay, Dorothy, we see your name. Are we? All right. Over to you, Dorothy. Your slides are up. Just tell us when it's time to advance. Yes?
Can I go on?
Yes. Go with your background slide. Can you see?
Yes, able to see.
Okay, good. Carry on. Thank you.
Okay, thank you. Good evening. I'm Dorothy Okage, presenting from Kenya, Kisumu County. And as you can see, the topic that I'm going to do is does collaborative workplace HIV self-testing kit distribution improve case identification among men aged 18 to 34 years, a case study for Kisumu County, Kenya.
Go to your next slide.
Yes, thank you. So in the background, despite the strategies implemented to improve HIV testing, uptake remains low among men in sub-Saharan Africa. And in Kenya, 27.5% of the men aged between 15 to 64 living with HIV do not know their HIV status, compared to 17.3% among the women. Kisumu County Department of Health, in collaboration with Population Services Kenya, launched HIV self-testing kit distribution for men at workplaces. We assessed its impact on HIV testing and case identification in Kisumu County, Kenya. In April 2020, PSK Kenya, in collaboration with Kisumu County Department of Health, trained 30 peer educators to distribute HIV self-testing kits in formal workplace hotspots were then mapped, and eligibility screening was done for all persons that were identified. Clients were offered options to test on-site or off-site, with trained counselors following up off-site clients via phone calls for their experiences and reported the results. Clients who reported positive results off-site were offered confirmatory tests in a facility of their own choice, while on-site testers were offered confirmatory testing and linkage to ART upon testing positive. Data was aggregated onto monthly forms and remitted to program District Health Information Software, that is DHIS system, an update for HIV self-testing kit testing, positive and linkage was described using frequencies and proportions. The lessons learned as at July 2021, a total of 43,880 HIV self-testing kits were distributed, with 74% received by men between the age of 18 to 24 years, of which 72% kits were issued to off-site testers. A total of 5.
Dorothy? Are you there, Dorothy? We can't hear you very well.
At 2.9%. Of the total positives, 65.3% clients had confirmative tests, with 97% confirmed 88.9% clients were successfully linked to ART. Our recommendation: HIV self-testing enhances case identification among men, hence the need to scale up the initiative among men to complement other approaches in improving identification among this group. Thank you.
Thank you very much, Dorothy. We finally made that work. Very well. Thank you. We will move on to the next one. Outcomes of a nerve center approach to achieving the 90-90-90 HIV targets in Johannesburg, South Africa. Mpefe Ketlapile.
Okay, can I, will you help me with the slides? Unless you want me to do it. That's fine, thank you. Afternoon, everyone. I hope you can hear me. I'm sharing with you from Johannesburg, Health Metro, outcomes of a nerve center approach to achieving the 90-90-90 targets in South Africa, as stated, is in Johannesburg Health District. So I'm just giving you a little picture of where Johannesburg municipality is sitting, and it's just in the center of 7 sub-districts for health in Johannesburg. And the next, if you can just point, it's within 7 sub-districts, and I hoped that would have been shown in the previous slide, but this one is showing that we are a robust city with all the indications of an urban metropolis. As you can see, we have hotels, there's third world items and kind of indicators, and young people and old people, and it's just an indication of how the metropolis is looking like. So South Africa is one of our countries still mostly affected by HIV, with an estimated disease burden of 7.9 million people. And in Johannesburg Health District, the metro consists of 9% or contributes 9% of the disease burden for HIV. In 2019, Johannesburg Health District adopted a national data-driven Potoma project management approach, sometimes called a war room approach, to derive a solution for achieving UN/AIDS goals. Just kindly note that we are still using the 90-90-90 indicator as goals. At the national level and provincial level, we have to be directed to use the 95-95-95 goals. In December 2021, the city of Johannesburg had achieved 93% for people with HIV knowing their status, 77% on ART, and 89% with a viral load suppression. In March 2022, this year, we augmented the project management war room with what we call a nerve center approach. And it is a coordinated problem-solving model which enhances interventions that we aim when we use to drive program improvement for the 90-90-90 goals. So our paper describes the outcomes of this phased approach and in improving the ART program, the timeline from 2019 to 2022. Next one. So as everyone knows, the 90-90-90 objectives in the antiretroviral program is to continuously increase numbers of people knowing their HIV status, increase numbers of those who know their HIV status initiated onto the ART program, and retaining them in care. So our methods and descriptions is that, as I said, we implemented a nationally approved and mandated Operation Potoma program, and it is focusing to improve the ARV program, looking at indicators specifically, and we replicated this at the district, sub-district, and health facility level. We implemented the program with core elements that we believe for a war room would be able to give us the outcomes that we want. So one of the approaches that we did was to strengthen management systems, strengthen reporting frameworks from the district and the sub-district and the facility level, look at data continuously with what we call a granular weekly data monitoring and analysis. And this ends up with the monthly data dashboard, where we sit in a meeting where we look at the dashboard performance for all the sub-districts as they contribute to the district performance. And the facilities implement what we call treatment acceleration plan meetings, which we call TREP meetings. So all these forums, we engage discussions and decisions within the NEF Center approach, guided by the data that is presented either weekly, monthly, or bi-weekly at the sub-district level. So we also implemented the intervention later with a NEF Center approach, which is mostly the direction of what I'm sharing with you, where we look and hone on performing indicators and we target them to improve, to improve program performance with the interventions that we implement. So in the facility level, we look at health system strengthening by the facility operation manager and her staff, systems redesigned through the meetings, the decisions, discussions that we have, where either staff will be rearranged for systems improvement. We identify whether there are training needs, and we continuously do this through continuous weekly and monthly information sharing and feedback. So I'm just describing to you the data as we analyze using the descriptions of what we achieve as we are implementing. So it is a timeline. As I said, it's a phased approach, which started in 2019, and we are in 2022, and I'm just describing to you all these facets and all these core elements that we are implementing to try to improve the 90-90-90 indicators. So at the national level, as I said, we do have the project management room model, which I said we call the war rooms. And at the national level, we were given a 10-point plan framework that was developed nationally to try to improve the indicators. And this is done at provincial, at district, and at the sub-district level in order to just look at the declining performance and to try to improve it. So at the national level, our mandate is to achieve this deliverable at management accountability. Facility level, they have to implement improvement plans, and we have to continuously look at the data at the metro and within the provincial health district. And at the facility level, when we started, it was weekly review of data using the TREP reporting tool. So in 2020, as we responded to the HIV pandemic, we started to redesign health systems so that we can ensure that we won't lose people when the COVID pandemic hit us. So during the high alert levels, number 4 and number 5, we sat in meetings and we strategized as a district and province on how we will keep our patient in care and preempt loss to follow up. So the government messaging was that we should not be losing patients. We strengthened our differentiated care models to address retention in care by redirecting our SOPs, and we implemented a 12-month repeat prescription strategy for all our ART patients, our TB patients, and NCDs patients, so that they were provided with medical packs over 3 months, and for 12 months with a 3-month refill, In 2021, as the COVID pandemic slowed down, so we were mandated also to try to catch up and try to get back the patients who were in care that we had lost. So all the districts had to implement measures to re-engage patients in care, navigate them back using the Welcome Back campaign, tracing, tracking patients, and referring them back to care. We resumed the project management rooms, which had stalled during the high alert levels for the pandemic. And we found that we needed to train our health facility managers in quality improvement so that we can fast track improvement into care after the pandemic. And we continued with our monthly data program review. So as of this year, nationally, we have also been mandated to augment the war rooms, looking at the nerve center approach. So here, the approach is mostly at facility level with core elements that also stress looking at data with granular data analysis, using barometers for weekly data performance monitoring, using performance charts at the facility level to try to assist facility staff to look at data for improvement. We look at systems analysis for service delivery, and we look at the pathway of care and what could be in the pathway of care leading us to losing patients in care. We do week-by-week charting of performance, and we identify drivers of program performance in the decision-making meetings using the World Health Organization Health Systems Building Blocks, leadership and governance, teamwork, trying to improve service delivery, and all other aspects of the WHO building blocks for healthcare. So our data, looking at the cascade in this figure, as stated earlier, Johannesburg Health District has achieved 91% and close to 92% of people living with HIV who know their status. We have achieved close to 70% of those who are HIV positive being initiated into the ART care regime, and the third 92% of this population being virally suppressed. The second is just a timeline with the first cascade, where we just showing you from 2017 how the ARV program cascade is progressing in Johannesburg Health District. So if you look at 2017, for the cascade, we were 75% knowing their status, 65.4% on ART, and 84% virally suppressed. If you go to the next slide, as I stated, we started in 2017. Just to show you what happens in the next slide, from January to March, which is the end of our financial year, we have 91% in the cascade knowing their status, almost 70% initiated into care, and 93% being virally suppressed. Our April to June shows some kind of progression, still staying with our achievement of 91%, and some fluctuations when you look at the viral suppression. So this one is showing you how we are tracking our total patients remaining on ART for Johannesburg Health District, and we compare this in the two past financial years, 2020, 2021. If you look at the far end on my right, for the financial year 2021, 2020-2021, we had retained 422,000 patients in care. And when you look at our orange line for the financial year 2021-2022, we have retained our total on ART at 449,568 patients. And this is the progression as we are trying to put patients in care and retain them in the Johannesburg Health District. So our summary of these results is that we have achieved the first 90. We are progressing towards, slowly towards initiating patients on ART, and we are having a very significant upward trend in patients remaining on the ART on ART if you look at our targets. We are learning that through the nationally mandated program as it started in 2019 and in 2020, implementing the war room model and the project management room and the NEF center approach, the framework can improve ART program performance. And we are illustrating that if you look at service delivery and identify where patients might be lost or might lose on a service through the step-by-step approaches and looking at service delivery, you can be able to identify how we can maintain and improve services. We look at granular data and we try to assist facilities to look at data for improvement. And we are believing that this can lead to improvement rapidly at the sub-district level when the interventions are done by teams at the lower level. We believe that a multifaceted approach which can demonstrate core elements that can drive outcomes, and we are believing that this can be replicated in urban metros. We believe that a NEF center approach where facility staff and sub-district staff sit down and rapidly look at the data, review performance, and continuously monitor, we can improve performance. We believe that information dissemination through our weekly, bi-weekly, and monthly meetings can lead to replicable strategies that others can adopt. We trained staff just after the COVID pandemic, and we believe that training management in quality improvement, use of standardized tools can lead to a performance of indicators. And we believe with the first 90 that we can start moving towards the 95% goal for the 95 goals. We are seeing challenges still in putting patients into care, but we have attained our total remaining on ART through the NEF center approach. Our last slide is that we recommend that implementation of the NEF center be replicated and learned, and if we put this in place and the approach with the core elements, overall service delivery can be improved, and we can be moving from the 90-90-90 goals to the 95-95-95 UNAIDS goals.
Very interesting. Thank you, Mpefe. And we will move on now to Noah Mancuso. Noah will present on mobile app-based ordering of HIV self-test kits and associated factors among gay, bisexual, and other men who have sex with men.
Okay. Good afternoon, everyone. Thanks for joining us. My name is Noah Mancuso. My pronouns are he, him, and I'll be presenting on behalf of the M-Cube team on factors associated with mobile app-based ordering of HIV self-test kits among men who have sex with men. So just a little background for the US. In the past 10 years, we've seen a decline in the number of new HIV diagnoses, but this trend has not been consistent across all groups. For example, MSM aged 25 to 34 have seen an increase in new diagnoses. Also, the Latino and Hispanic population has seen increases, while Black MSM rates of diagnosis have remained the same. We know that we have prevention tools to stop the spread of HIV, but uptake has been suboptimal. In the US, CDC currently recommends testing at least annually for active MSM, but our national surveys show that only about 50% of MSM are testing in accordance with those guidelines. And that's where online and mobile app-based ordering of testing has come in. So we've seen a lot of studies recently looking at the distribution of free tests via these mobile and online app services. Some RCTs have showed promise in increasing testing rates, but we kind of lack some implementation programmatic evidence of how well this works. There's also some concern about a digital divide and whether or not we'll increase the current disparities that we see by age, race, ethnicity, and location because we're using these online services. Yeah. Oh, there we go. All right, sorry. Okay, so that's where M-Cubed comes in. M-Cubed is the mobile messaging for MSM app. This was developed from the HealthMinder app, and it was developed using social cognitive theory. It also used several rounds of feedback from public health professionals, community-based organizations, and most importantly, MSM themselves. The app provides tailored text and video messages to participants based on their risk profile. It also allows screening for HIV and STI risk. You can do PrEP and NPrEP screening and find location services for care towards you. They also have commodity ordering, so participants can order HIV and STI self-test kits, as well as condoms and lube. So an RCT of the M-Cube trial was conducted among 1,200 MSM in the US, and we collected behavioral data and app interaction during the trial, and it actually found that men who were assigned to the app intervention, which meant that they had access to ordering those HIV self-test kits, were 2 times as likely to test compared to the controls. So this was great findings, but it raised a lot of other questions for us. One of which is what is predicting this app ordering, and then another concern was, is there differences in ordering or predictive factors based on certain populations or characteristics of people? Again, we don't want to further exacerbate some of those disparities that are so prevalent in the US. So our research question was looking at an outcome of ever ordering an HIV self-test kit, 1 or more during the intervention, and we had a range of covariates. We had one set that was guided by the literature based on what we know to be predictive of the current epidemic. And we also selected other covariates based on a theoretically informed model. And on the screen is that model. So because the app was developed using social cognitive theory, we hypothesized that variables related to social cognitive theory would actually be predictive of test kit ordering. So for example, at baseline, we asked participants to self-report if they had ever been tested in the past 3 months, the past 12 months, or ever for HIV, and we mapped that to the behavior domain of social cognitive theory. So this is all of the domains and the variables that we looked at related to the theoretical framework. And then the methods we used, we looked at only the HIV negative participants who were assigned to the app intervention from the RCT, and this came from data in Atlanta, Detroit, and New York. We used logistic regression in 2 ways to do our analysis. The first was doing a bivariate analysis, so all of our covariates of interest were conducted with bivariate analysis of our outcome, and anything that was significant with a p-value of less than 0.05 was considered for inclusion in our empiric model. We'd also chosen some variables a priori related to the demographics based on the US epidemic that we know are predictive of it, and we included those in our final model regardless. And that final model was a multivariable model, and we used log binomial transformations to get adjusted prevalence ratios. So here are some of our demographic results. We had a total of about 415 participants included in this study. Roughly 50% ordered and 50% did not order. Our mean age overall was 33, and we didn't see very much variation between those who ordered and didn't based on their demographics, as you can see here. In total, about 50% of our participants identified as white, non-Hispanic, and about 2/3 had a bachelor's degree or higher. We also saw relatively equal distributions of income across our study participants. On the screen here, you'll see some of our selected findings visualized. We hope to have the full set of findings published soon and easily accessible for everyone, but these are just some important ones we would like to call out. The first set here are related to our demographics. So we're looking at age, race and ethnicity, and geography or site. And as you can see, none of these were statistically significant based on who ordered and who did not. On the bottom, we see some of the variables related to our social cognitive theory framework, and these were significant in predicting ordering of self-test kits. So we have the behavior variable, which was reported history of self-testing. So we saw significance both in those who had not tested in 3 months and the past 12 months. Due to collinearity, we just include 3 months in our final model. We also saw significance in goal setting. So this was participants' self-reported plans to get tested, and self-efficacy, which was participants' self-reported likelihood that they would get tested. Goal setting and self-efficacy also had some collinearity, so we just included goal setting because it had a stronger explanatory value and it was more related to the app's programmatic details. So after that bivariate analysis, we created our final model, and behavior and goal setting remains statistically significant. So participants were 30% more likely to order an HIV self-test kit if they had not tested in the past 3 months, and they were 60% more likely to order a self-test kit if they reported plans to get tested. Also important to call out here that we did not see any statistical differences in age, race, ethnicity, income, and our other demographic variables. And we just wanted to call this out because we know that these are very predictive of the current epidemic in the US and wanted to show that this is maybe a way to get around some of those disparities that we see. So based on those results, we believe that mobile ordering of HIV self-test kits can reach under-tested populations. We saw this because participants who had not been tested prior were more likely to order an HIV self-test kit. We also think that ordering via mobile apps is a great way to supplement community and clinical-based testing. It won't serve as a replacement, but if we want to increase overall testing, we should be seeing a blend of both in-person clinic testing and self-testing at home. Likewise, we also think that mobile app-based ordering can align MSM intentions with actualized behavior, and we saw this with that goal-setting predictive significance as well, because MSM who said they wanted to be tested were more likely to order a test kit. And lastly, we just wanted to call out again that we believe mobile app-based ordering can help overcome some of those structural barriers to HIV prevention services that we see in the US based on a lack of significance in a lot of our demographics that are currently predictive of the epidemic. So all of this to say, we made a few conclusions here. The first is that the ability to order free HIV self-test kits via mobile apps can help remove barriers to testing and help MSM follow through on their intentions. Secondly, we know that accessible and frequent HIV testing for key populations is crucial for ending the epidemic in the US, and we think that offering free HIV self-test kits should be a critical component of this larger system of testing strategies. And that's all I have. Thank you to the MCube team and our funders.
Very interesting. Thank you, Noah. I just want to ask one more time if Jitendra Misra is either in the room or online. Going once, going twice? Okay, so that one we don't have. Okay, well, again, let's give a round of applause to all the presenters. I think it was very good, very interesting. Thanks for the patience with technical issues. We do have some time for questions, which is good. We have about 15 minutes before the session should end, so can we take some questions? I hope our presenters are happy for us to take questions. Any questions from the floor? If you have questions online, please add them, but any questions from the floor here? We've learned a lot. Okay, I have one quick question for Noah. I was interested in that app. Is the delivery of the free test kit also free, and how was it ordered? not ordered, how was it advertised?
Yeah, so the use of the app was free in the RCT, and the ordering and everything was free for participants. They got at-home tests, and they got the results themselves.
Sorry. Geez, I should have left this teeth. Yeah.
So use of the app was free in the trial, and ordering was also free along with shipping. They got a rapid, I think it was an OraSure test. So they got the results immediately. And what was the last part of the question?
Well, how was it advertised?
Oh, so I think recruitment was done via dating apps for MSM. Yeah.
Okay, any questions? Yes. Usually takes one to open the door, right?
Thank you. I think my question is directed to Noah around the ordering of the HIV self-screening test. This is something that we're also trying in our setting in South Africa amongst men who have sex with men and transgender people. I think one of the things that we are grappling with is how to get the results of these tests back. Would you care to share whether you were interested in getting the results of the test or it was just an ordering strategy? Thanks.
Yeah, so definitely can talk more after, but I think in the US we have a unique situation that is maybe different than other countries in testing and access to testing. So leading up to this RCT, there were actually several other RCTs done comparing returning of tests and linkage to care. And those RCTs following up to this one actually showed no difference in linkage to care based on self-report at home or being tested in the clinic. So that's kind of what guided the ability for us to offer those at-home tests without needing to report for this RCT.
Anybody else? Okay.
Hi, in regard to the peer mentoring, you mentioned, I think, a wrap-up aspect to the program. So once people achieve viral suppression, they can stay in on monthly meetings, and is that forever? Is that for as long as they want to? Like, is there a time frame that you kind of feel people leave the program, and do you experience people who kind of leave and then all of a sudden you find they no longer have viral suppression, they come back in? Can they come back in directly? Do they have to be re-referred in through their doctor?
Mm-hmm. Am I on?
I think yes.
Yeah?
Yes.
Well, if they relapse, once they've been referred, they can reconnect with me at any stage. We make sure to offer different options to them. Like, now you're undetectable. Do you think you need wrapping up of mentoring? Oh, I do, I don't. Do you feel like you need monthly checkups? If anything happens along the line, feel free to get in touch with me. You know, the door is always open for them to reconnect with any of those different options for them.
And I think, am I on as well? I think that was a development as part of the project. Initially, I don't think we'd thought about it, that if someone becomes undetectable, leaves the project, that they may then have a detectable viral load later down the line. And we saw that some people who had achieved being undetectable, you know, various things happened in their life and then they became detectable again. And so that's why we really sort of created the wrap-up, created this monthly check-in if people needed it, and also the pathway to come straight back into the program if you felt that they wanted it.
I think that's the good thing about the project. It's very organic and the quality improvement. Oh, now you're undetectable, what happens next? So it's still an ongoing process, including the mentee to mentor cycle. Not everyone is engaging with this, but it's good to have the opportunity to offer that platform for them.
I also had a question about the peer mentoring, and I'm thinking about, like, given what you found, what that looks like in implementation. And so a couple questions are, with one, say, full-time person doing this, how many clients do you think you could serve in a year, for example, counting how often people come back? And Do you have any thoughts about, in many settings, our ability to find money for some of these services comes down to well, a number of issues, but one of them is making the case that it actually could be cost-effective or cost-saving, I suspect. So the two questions are, how many clients could one full-time counselor serve over, say, a year? And do you have any thoughts about doing cost analyses and what the downstream sort of cost benefits are?
Yes, I've been leading this project for the past 2.5 years, and we've had a total of 97 referrals. That doesn't mean that everyone is engaging with the project. So on average, there's about like 10 people engaging with mentoring at the moment, plus the clinic work I'm doing like at the Harrison Wing, attending a young adult clinic, and also at the Caldecott Center, where I take part in multidisciplinary meetings and ward rounds, etc. So it's about catering in different ways at the clinics, but also one-to-one with the clients, which can be over the phone or face-to-face.
And I think to answer your second part, I think one of the key benefits or things that has been a success of this project is in some ways valuing the peer mentor through employing them as part of the team. In previous peer mentoring projects, they're sort of a peripheral thing that you refer to over somewhere else. And so having someone within the team that's a member of the clinic makes a huge difference. And I think that this project definitely proves in terms of success that it's worth doing that for the people who are difficult to or hard to engage. And certainly we know from cost analysis that someone who ends up as an inpatient can cost many, many thousands and can have a long, admission, 6 months or something like that, with opportunistic infection versus being able to catch someone earlier, get them into peer mentoring if they would like to, and then achieving success. So I think it does have, we've not nailed it down to exactly the cost completely, but I think you can see that it does have huge cost benefits.
I just wanted to ask you, what were the measures for mental health, for those that are suicidal, those that are depressed? How do you measure those? What tools do you use?
Ooh. I mean, that's a global problem, especially these days with war and different pandemics, monkeypox, COVID, cost of living. I think everyone's a little struggling with mental health, and especially if you are dealing with an HIV diagnosis that's not managed, and housing, migration, as we spoke about earlier. So other than referring them to the relevant services, my message is often about the self, like self-care, self-respect, even like self-regeneration, remembering the personal achievements they've accomplished in the past. Sometimes I'm referred people who have 2 degrees and a master's on something, and I'm like, well, if you've achieved that, obviously you have the skills to manage health. So that's what I call transferable life skills. There are many things we have done that we can implement and transfer to the current situation, including mental health. So yes, referral and working with the clinical teams as well, during MDT meetings and so on, and making sure that we are providing them with the different signpost referrals, or counseling, mental health support, medication when needed.
Does that answer your question? The tools for measuring mental health. So there are some internationally established tools, so that you end up knowing that this person is suicidal. So what kind of questions do you ask? Or if you end up knowing that they have low self-esteem, what guides you towards that so that we can learn? Do you do the questionnaires yourself, or are you using something that has already been established?
I mean, if you're talking about suicidal ideation and things like that, then you have safeguarding processes. It's happened a couple of times where patients feel suicidal. So again, I speak with the clinicians, like, this is what's happening for this client. And then I get involved to an extent, because my role is as a mentor. I'm not a counselor, I'm not a psychologist. So I need to refer them to a different service and make everyone aware this is what's going on for this patient.
And I think to just come from the clinical side, within our clinic we don't use specific like PHQ-9 or anything like that for assessment. but we have direct links with psychiatrist services and psychologists who work within our clinic as well. So we have got a direct access pathway if someone's identified as having problems.
I think it's clear, yeah. Okay. Anybody
Thank
else? Anyone online have a question? Okay. Well, I think that brings us to a close. We have 3 minutes to spare. Well done to yourselves as an audience and to all the speakers and presenters, and thank you very much. Enjoy the rest of your conference.